Dr. Sean Fogler is a community outreach coordinator at the Pennsylvania Harm Reduction Coalition, a person in long-term recovery, physician, and certified recovery specialist. He has over 15 years of experience in the healthcare industry, working as a physician and with patients, administrators, and insurance organizations. This is a two-part episode. In this first part, we talk about how common a substance use disorder is among physicians and why we are at higher risk than the general public. He then gives guidance on where to go to seek help if you have a substance use disorder. We discuss physicians' health programs and some of the positives and areas for improvement of those programs, and he then discusses some critical elements to recovery. Sean is active in the recovery community and has a special interest in trauma and substance use disorders in professionals. He volunteers as a peer support specialist for Lawyers Concerned for Lawyers and works to improve public health policy for mental health and substance use disorders. Through his lived experience, he educates, informs, and works to battle the shame and stigma that keep the disease of addiction alive. Sean's role at PAHRC involves engagement, education, writing, speaking, fundraising, and expanding knowledge of the disease of addiction and harm reduction. Sean holds a bachelor's degree from the University of Toronto and a Doctor of Medicine degree from Ross University School of Medicine. He completed an internship in internal medicine and a residency in anesthesiology at Hahnemann University Hospital in Philadelphia.
Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. And now, here's Dr. Bradley Block.
Dr. Sean Fogler, thanks so much for being on the show today.
Thanks for having me.
So let's start with the macro view of addiction in physicians and then get to more of the micro view. So first, how common is addiction in physicians?
Well, I mean, this is something that's actually very common, more common than I think many of us realize. In the general population, they say people with a substance use disorder are around 9 to 10%. It's hard to know exactly with physicians, but the numbers seem to be somewhere around 15%. And that can vary actually with specialties. So anesthesiologists tend to have a little higher rate. Psychiatrists, especially female psychiatrists, tend to have a higher rate. So it does, there's no exact answer, but it's more common than it is in the general population.
Why do you think that is? Why do you think we're at higher risk?
I think there's so many different factors. Even if you just look at general factors for addiction, psychological, biological, things like anxiety, depression. We work at a very high pressure, high stress environment where lives are at stake. I think a lot of it has to do with the systems we're in, and especially nowadays, as you know, with electronic medical records and more administrators looking for data and pushing us to work, longer, harder, faster. And this causes, you hear about burnout and compassion fatigue and trauma, vicarious trauma, almost like PTSD in a way, where people can feel very isolated. They don't feel valued. And I think one of the most important areas that leads to substance use disorders in physicians is the culture of silence, where we don't feel safe to come out and share, hey, I'm stressed out. Hey, I feel depressed. Hey, I think I'm drinking too much because of professional, judgment, fear of consequences, right? If somebody reports you to, your chief or to the medical board, the consequences can be quite traumatic. So I think we have a culture of silence and we don't talk about this stuff. And I think many institutions talk about improving the culture, creating wellness programs, but it's almost like lip service. It's like, this is what we're supposed to be doing, but they're not really providing the time, the energy, and the most important thing is probably the safe space, right? A space where you can share your struggles without fear of retribution in any way.
Yeah, this seems to be a theme in our profession. I had an interview a little while ago with Stacia Dearman about litigation, and that's something that we're not allowed to talk about, right? Like if you're involved in a lawsuit, you're not allowed to talk about it, and that actually has led to physician suicide,
right?
Because you're involved in this. You feel terrible about something that happened, and then the lawyers weaponize that against you, and then you're already in an extremely high stress situation, and that has on occasion turned out to lead to suicide. So the fact that we're so siloed and that all they're doing is paying lip service, right? They create a wellness program because they're supposed to. Now, what's the science and the data behind a wellness program? I actually don't know offhand, but I would assume very little. Whereas the safe space seems to be really a great solution to this problem. But what is their solution aside from the wellness programs? Let's say you do have a substance use disorder and you want to seek help. What is our current system for that?
Yeah, the system is not good. It really isn't good because it's funny. I was thinking about this the other day, and there's I was thinking about all the things that an individual, a physician can do if they feel like they're struggling with a substance use disorder. And the last thing on my list was a physician's health program, right? Which is awful. And it tells all because, a physician's health program, which is supposed to be about health and wellness for practitioners, is a monitoring agency that says they're about physician health and wellness, but what they're really doing is protecting the medical board, protecting the institution, and they're monitoring agencies. And so, if I had it starts with being honest, which is really hard when somebody does have a substance use disorder. Part of the disease is isolation. Like I always say, addiction or substance use disorders are diseases of isolation, and you become disconnected from yourself and from reality. So, and from the world around you, and so, and there's all these, and it's rooted in fear and shame. There's a tremendous amount of shame, and so, I think starting with your family, if you can talk to your family. I think having a therapist or connecting with a therapist is a great place to start. Mutual aid groups like AA and NA are great places to engage with people. If you can take that step, which is really hard at first, really, really hard. There are recovery communities. There's Caduceus meetings, which, I've been going to a Caduceus meeting for almost 5 years now. Where it's just doctoral level healthcare professionals. And those are great places too. Anonymously, you can contact employee assistance programs. So there are a lot of things. The last thing I would do would be pick up a phone and call a physician's health program, or even talk to I think, talking to your colleagues, talking to, say, you're the chief of your department is tricky. Some places that's probably a great thing to do and beneficial, and in other places it can be catastrophic.
Ultimately, you don't know what they're going to do with that information, right? Whereas if you're with a therapist, aren't they obligated to keep it confidential?
Right. Exactly. And that's the first place I would start. You have to find somebody who's trusted, and where you can share this stuff in a safe space. That's one of the other things I do on the side, and I can get into it a little bit more later, but I volunteer for this organization called Lawyers Concerned for Lawyers. And they provide peer support to lawyers, judges, and their families, and law students as well. And they do a better job than we do. They do a much better job than we do. And it's all anonymous. The goal is to get you back to work healthy and whole. And it's not punitive at all. Obviously, there's extreme examples. I mean, if you land in the paper and, your substance use disorder takes you in a direction that leads to something dramatic, there will be more monitoring. But in general, it's a softer, gentler way and approach that's rooted in the idea of getting you healthy and back to work. And with physicians' health programs, it's not like that at all.
So you keep mentioning these physician health programs, and I think it bears discussion what this is. So yeah. I've heard if I hadn't listened to your podcast, I don't think I'd know what a PHP was. So what is it? What is
I had no idea what it was until I landed in one myself. But a physician's health program is a program, and not every state has them, but almost every state has them. And they kind of operate in conjunction with the medical board, and they focus on physician health and wellness. And it's usually physicians that are struggling with substance use disorders. Sometimes it's behavioral issues. For a substance use disorder, at least in the state of Pennsylvania, what happens is you sign a 5-year contract, the physician's health program, and your license usually stays intact, and there's no public reporting of your issue. And there's certain things that you have to do. And one is going to therapy. One is going to group therapy. The other thing is, going to a certain number of 12-step meetings every week, which need to be logged in. It also involves random urine testing, screening. And depending on the individual, there may be some other requirements as well. And as you progress through it, the testing goes down. Eventually, you don't have to do group therapy. And if you listen to the physician health programs, they have very high success rates. And we don't know. See, the problem is there's not really any oversight to physician health programs. They don't share their data, so we don't know the exact numbers, but historically they claim very high success rates. That's kind of the short of it.
So that sounds reasonable, right?
Yes.
You go to group therapy. There's a monitoring program because part of the reason this exists is it's a patient safety issue. So you have to make sure that the practicing physicians that have a history of substance use disorder aren't actively using substances. This all sounds reasonable. However, there are some flaws in their system. What would you say where is there room for improvement in this system?
I think if it's if these programs are really about health and wellness, I don't think a cookie cutter approach is the way to go. And they really plug everybody in, for the most part, into the same general program. And for me, I didn't have an issue with it. When I entered the PHP, I was 1.5 years into recovery. I had I was already doing therapy. I enjoyed group. I was a 12-step person. But some people find it, they're not on board with 12-step. Maybe, their religious background, or they're atheist and they struggle with that.
Why would that be?
12-step programs are problematic for some people. It's all, it's rooted in the idea that there's a higher power.
Right. Isn't that the first step?
And yeah, well, admitting your powerlessness, that you're powerless over drugs and alcohol, that's the first step. But some people find that problematic, right? And so it's interesting. There was just a lawsuit, and this is in Canada and British Columbia, of a nurse that was denied his license, and he was in recovery because he refused to go to 12-step programs. And this went, I think, all the way to the Supreme Court, and he just won. There was actually an article on it yesterday that he should not have to be required to do these meetings, right? Now, there's others, because recovery isn't just 12-step. Recovery is many things to many people. And I always say it changes over time. So to me, recovery is going out for a run, right? Or being connected with, friends or family, or, reading or meditating. Like, it's not just 12-step. And some of these rigid programs, it doesn't sound like a big deal, but when you're forcing somebody, it's almost like forcing someone to practice a religion, right? For a certain amount of time that they absolutely are opposed to. And that's really not honoring their lives and, their life and their beliefs. The other thing is, we don't have any evidence that 12-step programs necessarily work. Like, they work when they work. I found it very helpful. Some of my colleagues don't find it helpful at all. And other colleagues find it actually harmful, and they really struggle with it. So I think we have to, like recovery and substance use disorders, it's really different for different people. And it's not like, if you have hypertension, everybody doesn't get the same drug, right? Everybody doesn't get the same diet. Like, it doesn't work that way. If it's a disease, we should treat it like a disease, and the solution is not always the same. And it's problematic. And the other, like, just the starting point to looking at these programs is we need to see their data, right? We don't really know what's going on behind closed doors. And you hear horror stories all the time of physicians committing suicide, being homeless on the street. And, for the right person, it works. And for other people, it doesn't necessarily work. But because it doesn't work, doesn't mean that they're not doing the right thing. Like the program itself can be a huge barrier, to recovery.
And then if they feel like that's not working for them, then they feel like there's something wrong with them. Why is it working for everyone else? It's not working for me. There's something wrong with me. And then that's going to push them back towards their
right. And then think about the stakes, right? So if you don't do what they say, you don't have a license. And then there's public disclosure, right? So they report you to the board. The board posts something publicly. Your license is suspended. You can't work, right? There's a whole cascade of events that occur that your life is, and there are physicians that are broke, that are homeless, because they're not able to, to move through these programs and do what is required. But what they are requiring doesn't necessarily mean you're successful and you're healthy, right?
Yeah, it just means you jumped through their hoops in the time that you needed to do it. Yeah.
Right. And addiction, addiction is a chronic, progressive, relapsing disease, stress-induced. Like, if you look at the ASAM definition, but after 5 years, you get your seal of approval and you can go and do whatever you want. Right? Which is just, that doesn't even make sense itself. Right. And my whole thing is, like, if we really are concerned about protecting the public, if we're really concerned about physician health and wellness, the physicians that are in the hospital or, in the clinics, offices, all over the country, we should be providing support for them. Right? Like they should be getting therapy, they should be going to groups and this is controversial, but, should we be testing them, right? Pilots get randomly tested. And I'm not advocating for that because drug and alcohol testing is problematic, in and of itself, but we're not doing anything for those. We're just taking a select group that had an issue, putting them through some program that maybe it has a great success rate, maybe it doesn't. There was a recent article in the New England Journal of Medicine by Leo Beletsky and Dr. Sarah Wakeman up at Harvard. And the article's entitled Practice What We Preach. And it's really focused on opioid agonist therapy for people with for physicians with opioid use disorder, which is Suboxone, right? And in these programs, Suboxone is a no-no. Right? You can't be on Suboxone or buprenorphine or methadone and practice medicine and have a license.
What's the reasoning behind that?
There's no, absolute, but the general thought process is that you're impaired if you're on these medications. But we don't have evidence. We don't really have good evidence on that. But what about, a physician that takes Ambien at night or takes, a Xanax or, some other benzo to go to sleep or is on some other psychotropic, some of these antidepressants? Are they? No, it comes down to stigma and our deeply rooted attitudes that these people are sick and flawed, and are not safe. But that's not the truth. And you should take a look at the article if you get a chance, because and I always say, that's the tip of the iceberg, because it brings into question so many of our attitudes towards our own colleagues, right? Like I always say, how we treat our own tells us everything we need to know, right? So how, I treat my colleague who's struggling with a substance use disorder really, shows us what we're thinking and what our beliefs are. And I think the stigma and the attitudes within the medical community towards people with substance use disorders is the worst, is among the worst. And I'm not saying there are some great people doing great work out there, but I think in general and as a system, we don't do a very good job when it comes to that.
If you were building a PHP program from the ground up, right? It seems like it's state to state, right? Like each state.
Well, that's the other problem. It varies from state to state. So these programs aren't even uniform, right? Like,
interesting. We should be able to use that data then, right? If they're so different, you can then compare which ones are more effective, which ones are less effective, what's the differences between them, to try and figure out what are the aspects of it that really help our physician colleagues the best.
And that's a great idea.
So let's say you had free reign, right? You're in Pennsylvania. Let's give you New Hampshire. I just chose that at random, right? You get to build it. You get to build it yourself. How would you do that? What would the PHP consist of?
Wow, that's a great question. I think I would start with sitting down with a group of physicians that have had substance use disorders in the past, currently have substance use disorders, and talk to them about exactly what are their wants and needs. And like from my understanding and what I know about recovery, having connection, having support, having purpose is critical, right? So, and it comes down to, the safe space, like we have to change the culture. Well, people, put people in a place where they can open up and connect with their colleagues. Obviously there would have to be a treatment component, an education component. I think you would have to involve hospital systems, senior leadership in hospital systems, and have them involved in the program, and just create a program where people can share their struggles, get the support they need. And this is it's going to vary because, some of it has to do with trauma. A lot of it has to do with trauma and dealing with trauma, and every individual is going to be different, right? So I just, to create one entire program, I think the way, the Lawyers Concerned for Lawyers does it, where there's an anonymous component, where you're protected, where you're referred, in a confidential way, to different resources that can help you and connect you. I think peer support is a massive part of this. Being paired up with somebody with lived experience that's been successful, that can guide you through and support you, is really, really important in all of this.
Like a sponsor.
It's like a sponsor, but I think more than a sponsor, because, a sponsor takes you through the steps of whatever program it is. Say that's AA. Peer support is much more. Peer support is someone you can look to and say, hey, like, he's had these struggles or she's had these struggles and has been successful, and this is what they did and this is how they got there. And a sponsor doesn't necessarily do that for you. I mean, a sponsor can be very important and is a really good sounding board, but I think somebody, a peer support is like the next level. And it's like seeing is believing, because a lot of times you get into recovery and things are bad. Things are really bad. And life seems hopeless. And, we're always comparing ourselves to other people. And unless you can see a path forward, it can be very, and I'm like a privileged, individual that had a ton of, support and abundance of resources that led to a very strong recovery. But most people don't have that. And everybody should have that. Everybody should have access to that. And I think aspects of the PHP are important. I think group therapy is really important. I think having a group of people around you that get to know you, that can call you on your bullshit, and give you insight into yourself is one of the most powerful things you can do. A group therapy, peer support, and support at work in the workplace. Because I think getting back to work, assuming you're in a mental state where you can be successful, is one of the most important things. And I was talking to somebody the other day about Viktor Frankl's book, A Man's Search for Meaning.
Oh, that's my Bible. Like that is like one of my favorite books. Yeah.
Yeah, and there's a line in there said like, "He who has a why can bear any how." And this is a guy that was in a concentration camp, like a psychotherapist, a psychiatrist that was living and was just trying to survive. And when you're struggling with a substance use disorder, it is about survival. I mean, it is primal. You are just existing and surviving. And then you step into recovery, and it is scary at first, and it's very confusing, and it can feel very hopeless. And I think like having meaning and purpose in your life is one of the most important things to recovery. And that's why I think getting back to work, especially for us as physicians, where we've invested so much of our lives in doing this, and most of us, it's our identity, it's who we are. And when you strip that away, which was my experience, which we'll talk about a little bit, that itself is extremely traumatic and very hard to deal with. And so I think getting back to work quickly, but then once you're in the workplace, you need support, right? It's because it's not, everything's changed. So you need guidance at work, and we need systems and people at work in our institutions that we can go to. And maybe it's having groups, in the hospital, having, a therapist or a peer support individual in the hospital that you can on your break go and, hey man, I want to talk about this. I want to talk about that. It's really about, like, in essence, it's about connection and support, right? And believing the people around you are invested in your success, right? And I think most physicians that are in these physician health programs, and I don't want to totally bash them because there is a lot of good in there. And my personal experience was actually very good. But I think for most people, it's a very adversarial relationship. They see it as, us versus them. And it shouldn't be. That relationship has to change, right? People don't believe they're there to lift them up and support them and make them successful. Their belief is that they're trying to catch me.
Yeah, they're there to catch them when they slip up, not there to help them not slip up.
Right, exactly. Which is a huge, it sounds like something small, but it's massive, and it completely changes the relationship. Because like most of us, right? Like the administrators, the insurance companies, the PHP, it's this whole constellation. It's like the whole system is out to get us, and we're working in it just trying to survive and trying to do good. And so I don't know if I totally answered your question. It's a great question, and I haven't thought a lot about that. But
you answered a lot of other questions that I had along the way.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. He can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, please be sure to leave a 5-star review on your preferred podcast platform. We'll see you next time on the Physician's Guide to Doctoring.